Thank you, Vinay, and AIS for having me here. And we'll try and run it a little faster to. So the basic thing is that indications of lens extraction in primary angle closure glaucoma. So Brown has summed it up beautifully in past, recommending cataract surgery alone to an angle closure patient with uncontrolled IOP, even in the presence of a visually significant cataract opacity, would have been controversial. Today, avoiding a trabeculectomy in these patients is an accepted practice. So how things change. So lens extraction alone should be recommended for any angle closure patient with a visually significant cataract and should be seriously considered as an alternative to filtering surgery. That we will see what we think about, but that is what he thought. So this is primary angle closure suspects. Angle closure where there could be a PAS and there could be a elevated IOP, and once you have this kind of a disc and field, you know that it is a primary angle closure glaucoma. So basic thing is, what is the cause of primary angle closure? Is it the pupillary block? And if it is the pupillary block either in the primary or secondary, then obviously we have to do an iridotomy, that's fine. Is it a platyoiris in which even after an iridotomy the angle goes up and you block the trabecular meshwork, in which case you need an iridoplasty. But ultimately, is it the lens? And actually all the time it is a combination of all these three things, and it is really difficult to differentiate which is which. So we all know that axial length is less in occludable angles, anterior chamber depth is less, lens thickness is more, and yes, compared to normalized, this is the situation. And then what came up was the lens vault, and the lens vault is the perpendicular distance between the anterior portion of the lens and the two scleral spurs line. And what was realized was that lens vault was significantly greater in both the angle closure group with thinner lens and thicker lens. But what Dr. Ramanji then stated was, and very truly, that if anterior chamber depth is deep enough, the lens vault, even when large, would be less likely to increase the risk of angle closure, and the converse is true, that if the patient's anterior chamber is shallow, the angle closure risk would be relatively increased even if LV is small. So what is important is the relative lens vault. That is lens vault oblique anterior vault, and that came out to be the much more respected stuff. And we see that relative lens vault was significantly changed as in PAC as compared to normal controls, and that is now the standard. Unfortunately, predicting which angle closure patients will benefit from lens removal, whether clear or cataractous, remains uncertain. So all these figures are very, very good, and yet you cannot really put your finger that, all right, if it is axial length is less than this, anterior chamber depth is less than this, lens is thicker than this, you go ahead and remove the lens. So there is no strict criteria for that. And what are you doing by lens extraction in angle closure? You can remove the iridolenticular block, you can deepen the chamber. But if any damage to the meshwork is there, that you are not taking care of at all. And you have to be careful, because ACG blindness is 2 to 3 times as compared to OAG, and once you have done cataract only and the patient thinks, everything is done, we are not worried, everything is cured. So that is something that we have to be really worried about. Second thing is, we always think that phaco is what is going on. No, a huge part of country SICS is the things. And how many people would even think once to sit on the temporal side and do a 6 so that the trap can be done from superior side? None. Thousands and thousands of 6 are being done, so we have to be very, very careful by saying that only go ahead and do a lens extraction. As far as the clear lens extraction, I am leaving the studies to Prateep, who will be doing the next talk. But clear lens extraction again is there. The Eagle study did a lot of disservice on that, and we have seen now so many people are so excited. 6, there is a small spoke of cataract in the periphery. Oh yes, there is a cataract, remove the cataract. So, but that can lead to loss of accommodation. I have had people I had a mason I had sent for peripheral iodotomy because he was a poor person, some thesis was going on, his lens was removed and he came back crying. Because there was a loss of accommodation, he could not work, it was extremely difficult. So please, lens extraction in a clear lens is a very difficult situation. When would I do a lens extraction? In ACG alone. IOP is controlled on tolerable medications with PI, gonioplasty, etc., detectable cataract. Extent of field, actually now for me, it really does not matter if I tell the patient clearly that, okay, I'm going to do a lens extraction. If I require to do it, I will have to do a trab later, maybe early, maybe late, but you should be aware that it may be required. And yes, if the patient is unable to stand a long surgery, unwilling to risk a snuff out, there is an advanced damage, patient is debilitated, and control is plus minus, you can do a lens extraction because absolutely there's no option, or you can add it on with DLCP or something like that, because you can't undergo big surgery. But very clear for me, if IOP is not controlled, and you can try a lens extraction, but for me, I would rather go ahead and do a combined surgery in such a patient with advanced damage and uncontrolled IOP as of now. As far as the clear lens extraction is concerned, for me, there's only one place. If the chamber is very shallow, you will have to do a trab, and you're scared of doing a trab in such a shallow AC, then yes, please go ahead and remove the lens and do a combined surgery in that case. Dr. Lam very promptly said that yes, we have done a study, and any IOP greater than 55 in acute angle closure glaucoma, please go ahead and do a lens extraction. We have controlled invariably almost all patients of angle closure by medication, PI and gonioplasty, and question of doing a lens extraction in acute ACG is extremely difficult. There's no doubt, there's a talk on that as well. We'll be talking on that as well, but it is a very, very difficult task. I don't think it is that simple at all, and I would not recommend it personally. So there's a detectable cataract, there's a visual acuity drop, IOP is controlled on medication, IOP is high, but disc is not too bad. Please go ahead and do a cataract. Otherwise, you will have to think of a combined surgery. Thank you very much.